Hello again, and thank you, and good afternoon. This time instead of good morning, and again, thank you to New Mexico Health Resources for allowing me to go on this trip with my wife and still present this information to you. So this next part is probably not near as interesting as the first part, and it's more, how do you treat chronic pain with non-opiate medications? And so when you look at things to consider, and some of this will be redundant after the first talk, but remember that pain is the most common reason that people go to a provider, be it a clinical a pharmacist clinician, a physician, a nurse practitioner, or a PA. And the other thing is that you have the competing agendas that we talked a little bit about on the first lecture of the Joint Commission, which says pain is a fifth vital sign, versus the DEA, which says we have a huge health problem, and it is a health problem. And again, if I'm pressed on who I'm going to believe or make sure I'm in line with, the DEA carries guns and the Joint Commission doesn't. The number of deaths have gone up, and when you look at the data, and I'm sure most of you have seen that it's a parallel line in this country. That is, we became more and more liberal prescribing opiate prescriptions, that there were more and more accidental overdose involving opiates. And again, when you look at the incidence of alcoholism or addiction in the normal population being 1 in 10, for every one person that takes that out of 10, it may be a life-changing experience. And lastly, pain doesn't equal Percocet. Yes, patients have a right to have their pain treated adequately. That doesn't mean an unlimited supply of oxycodone. So some things to think about when treating chronic pain, and I think these hold for any chronic disease. Nothing gets better without diet and exercise, be it diabetes, be it hypertension, be it hyperlipidemia, and chronic pain. Nothing gets better without diet and exercise. Nothing gets better without sleep. When you sleep, you rest, you renew, you process the day, and you heal. And nothing responds to medications alone. I've had numerous discussions with numerous patients that when you go to physical therapy and it hurts after the first time, that's not really a good reason to quit. Physical therapy has the nickname physical torture for a reason, and it's something you do over a period of time, not just once and say it made the pain worse. Rarely does anything respond to one medication alone. And much like when you treat hypertension with more than one medication and they have different mechanisms of action, the same thing with chronic pain. So in patients with chronic pain, things also to look at are depression. When you're depressed, your norepinephrine and serotonin centrally are decreased, and when those are decreased, you perceive the pain more. When your thyroid level is low, or when your thyroid is malfunctioning, you become depressed, and your norepinephrine and serotonin levels decrease. When you have low testosterone secondary to chronic opiate therapy, again, you become depressed. Your central levels of norepinephrine and serotonin drop. And also low vitamin D. Remember, vitamin D is a pro-hormone, and especially in rheumatologic conditions, fibromyalgia, low vitamin D can make the pain worse, and when you normalize it, people's pain often get a little better. Obesity is an issue a lot with lower back and osteoarthritis or rheumatoid arthritis, but especially osteoarthritis in the knees and hips, because the more weight you have, the more the joint's going to get hammered. But it's also a risk factor for sleep apnea. And if you have obstructive sleep apnea and then you're placed on an opiate that causes central sleep apnea, you do increase the risk for nocturnal hypoventilation. If you have a past medical history for PTSD, that's a risk factor for aberrant behavior. And again, as I mentioned in the earlier talk, the PTSD and chronic pain, especially fibromyalgia, tend to have parallel patterns, and when you have them together, it ramps up the severity of pain. And if there's a past medical history for substance abuse and addiction, that also can implicate or make more complicated how you're going to treat the chronic pain. Oops. So when you look at low back practice guidelines, again, when you compare this to any other chronic disease, and I know I hammer this point over and over, but I want to, because I want to, sort of put out there that the more you treat pain like any other chronic disease, I think the less you get in trouble. So with low back pain, if you have a diagnosis and if you have hard data like an MRI, I think that helps. If you have education on what the patient's to expect from the therapies you do, i.e. relieving all the pain, isn't a realistic expectation. And I'll tell my patients often that I can relieve all your pain. You will have no quality of life and you won't get up in the morning, but I can relieve your pain. And treatments. The first line of treatment is really Tylenol or NSAIDs, and then you go from there. When you look at osteoarthritis, again, orally, COX-2 inhibitors, Tylenol are the first line of choice, and then you get more complicated. Intra-articular opioids, which are not done that commonly, but glucocorticoid injections. And I can tell you, before I had my knee replaced in October, steroid injections in my left knee was the only thing that took the pain away. And unfortunately, they only did it for 2 or 3 days, and I couldn't convince anybody to give me these injections every 2 to 3 days. But that was the best method of having my pain reduced. Topical agents such as capsaicin, such as methyl salicylate, which is in a lot of the big gay over-the-counter products, are useful. The other thing is topical lidocaine may be useful. Fibromyalgia recommendations, and if you look at the new recommendations, they've actually changed to where the 11 out of 18 sore points at 3 millimeters of pressure are gone, and it's really now the definition of where the pain or where the patient says the pain is. It's still above and below the waist and right and left sides. But the first line of pharmacotherapy for fibromyalgia is tricyclic antidepressants. In our clinic, we tend to favor those. Personally, I haven't had a lot of effect, but they are one of the few agents that have documented relief. And if you do use a tricyclic antidepressant, remember that if you use a quaternary ammonium ion like nortriptyline or desipramine, that theoretically has less side effects, and I'll mention that a little more in the next few slides. Lyrica or pregabalin, duloxetine or Cymbalta, or Savell or milcalcipran also may help, and Lyrica by being an anti-seizure agent and stopping the signal to the brain, and the SNRIs by blocking the reuptake of norepinephrine and serotonin. Also with fibromyalgia, cardiovascular exercise is one of the leading recommendations, and it has other benefits such as generating and increasing endorphin levels, increasing blood delivery to the muscles to wash out toxins, and decreasing stress. Cognitive behavioral therapy, and again, when you look at the overlap of PTSD and fibromyalgia, it's pretty significant. And intense patient education, so that they can realize what are realistic goals, what aren't realistic goals, what are effective coping behaviors, what aren't effective coping behaviors, such as quote-unquote chemical coping with opiates. This is actually for diabetic peripheral neuropathy, and I apologize. The title didn't get in there. But the interesting thing is, when you look at the level A recommendations, pregabalin or Lyrica is the only one that has a level A recommendation. Level Bs are things that we also try, such as gabapentin, up to 3,600 milligrams a day. And the interesting thing with gabapentin is that once you get above 3 grams a day, the absorption becomes erratic. If you look at other anti-seizure agents such as venlafaxine, such as valproic acid, the problem with valproic acid is people tend to gain weight. And then there's the SNRIs are also on level B. Level C, or not recommended, I'm sorry, are other anti-seizure agents such as lamotrigine, central alpha agonist agents such as clonidine. Toxyphylline, based on the theory that if you make the red blood cells more flexible, they'll make it through the damaged blood vessels better, and you can increase oxygen delivery downstream to a better degree. Again, not recommended. Mexiletine, which is an antiarrhythmic agent, isn't recommended either. So we all know the WHO step ladder, and that's where we all start, with step 1 being Tylenol, which has recently taken a hit as far as maximum dose, and NSAIDs. Opiate mixtures, which are Tylenol 3, Tylenol 4, and hydrocodone. It does look like, given the mood of the country, that hydrocodone would be scheduled as a Schedule 2 drug and move from a Schedule 3 drug. And step 3 is opiates alone. And when you look at the difference between step 2 and step 3, it really is based on the fact that we think people will take less medication because they know, the Tylenol can damage their liver at a high dose. That actually hasn't proven to be that much of a deterrent. So NSAIDs. NSAIDs are great drugs, and what they do is they inhibit, and I apologize for this, and again, I bet you're reminded of the Republicans' rebuttals to Obama's State of the Union speech. So, NSAIDs, great drugs. They inhibit the formation of prostaglandins, which then downstream go to arachidonic acid and cause pain and inflammation. Now, the problem is that prostaglandins are ubiquitous throughout the body. So in the GI tract, especially the stomach, the prostaglandins increase bicarbonate production, which protects the stomach. So when you don't have the prostaglandins, because of the NSAIDs, you don't have that protection in the stomach, and you can tend to get a risk factor of developing GI ulcers or an upper GI bleed. When you look at the renal toxicity, again, the prostaglandins help keep the renal vasculature open. If you've got borderline renal blood flow, you decrease the blood flow to the kidneys, and then you have your serum creatinine can rise. You also have fluid retention, and your blood pressure can rise. So if you have borderline control of your blood pressure, that can also be a problem. Hepatitis can be a problem, and also if you have severe asthma, prostaglandins help keep the bronchioles open, and without those, the balance may be shifted to more bronchoconstriction. So with NSAIDs, you want to use in caution with somebody with a past medical history of an upper GI bleed. And when people tell me they can't take NSAIDs because of their stomach, I'll ask specifically, exactly what do you mean by that? And I'll ask them specifically, did you have an upper GI bleed? Were you hospitalized? Did you get a blood transfusion? And a lot of times it's more stomach irritation like nausea or reflux disease, which I think is a different issue. You want, again, based on what I just said about renal function, if somebody has borderline renal function, be careful with NSAIDs. And I have had a couple of patients over the years whose serum creatinine significantly increased after starting an NSAID. At that time, it was diclofenac that I was using, which has since fallen out of favor because of cardiac risk. Uncontrolled hypertension, uncontrolled bronchospastic disease, again, you need to use NSAIDs with caution. Tricyclic antidepressants are great medications if people can't sleep, because one of the side effects is sedation, so you can take advantage of that. Tricyclic antidepressants such as Elavil or amitriptyline, nortriptyline, which is Pamelor, desipramine, which is Vivactyl, which they actually got from the word vivacious, and imipramine or tofranil. What they do is basically what a lot of the other antidepressants do. They block the reuptake of norepinephrine, serotonin, and dopamine, causing increased concentrations in the synaptic cleft, causing a greater response. The main side effect to tricyclic antidepressants are sedation, which again can help if somebody can't sleep. Also constipation, blurred vision, hypotension, because they're alpha antagonists. They hit the alpha receptors and block them, which means beta is unopposed, and you can drop your blood pressure. One of the more common ones is also having a morning hangover. You want to use them carefully or contraindicated in patients with glaucoma, especially narrow angle glaucoma, and in pregnancy. Also, you want to be careful if somebody in males above 50 because of prostate enlargement, and it can cause urinary retention. They do have drug interactions, mainly with MAOI inhibitors, if somebody happens to be on those. But also, if you use them for sleep, you can get them into a range to where it really is a therapeutic range for depression, and if they're also on an SSRI, SNRI, you can get too much serotonin on board. And the last one that didn't make it on this slide is if people have a history of heart disease, especially widening of the QRS, you want to be very careful with them. So the next question is, okay, great, which antidepressant do I use? The SSRIs tend to have inconsistent results in chronic pain. The tricyclics, if you want more of a norepinephrine response, amitriptyline, and again, if you use desipramine or nortriptyline, they're quaternary ammonium ions, they're polarized, which means they may cross the blood-brain barrier less and you may have less side effects. The other part of that equation is they may cross the blood-brain barrier yet less, and you actually may have less efficacy. If you look at the SNRIs, I generally go with venlafaxine first, mostly because of the requirements by the insurance companies that they have to fail that. And if you look at the three drugs in this class, venlafaxine, duloxetine, milcalcipran, venlafaxine is mostly serotonergic until you get to the upper doses, like 225, 300 milligrams a day. Then it has some norepinephrine effects. Cymbalta, as far as norepinephrine and serotonin, is 50-50. And Savella is more norepinephrine than anything else, and predominantly norepinephrine. For what it's worth, on a personal note, I've had better luck with Savella than any of the other SNRIs, but it's also the hardest one to get. When you look at anticonvulsants, and again, anticonvulsants paired with an SNRI make good sense. The anticonvulsant shuts the pain signal down to the brain or decreases it, so there's less of a signal to respond to, and the SNRIs increase the levels of norepinephrine and serotonin so that that pain signal is tolerated better. So when looking at the anti-seizure agents used in chronic pain, the one that has the best data are gabapentin and pregabalin or Lyrica. And they actually act at the same site, at the calcium subunit of the receptor. And also, if you need to, you can use another anti-seizure agent like carbamazepine, oxcarbamazepine, or trileptal with the gabapentin or pregabalin. They act on different nerve receptor channels, and again, using two different mechanisms of action, you may have an additive effect. Where you have to be careful with anti-seizure agents are with liver disease and monitor the liver enzymes. You can get weight gain, especially with valproic acid, more nausea, hair loss, and the older anti-seizure agents have a significant amount of drug interactions. Carbamazepine is the quintessential cytochrome P450 enzyme inducer. Valproic acid, or Depakote, is a cytochrome P450 enzyme inhibitor. So you do have to be careful if they're on medications such as warfarin, and you put them on carbamazepine. That's going to change the INR. If they're on birth control pills and you put them on carbamazepine, it's worthwhile to tell them to use a second method of birth control while they're on the carbamazepine. Oxcarbamazepine or trileptal tends to have less interactions, less adverse effects. Doesn't mean that they're not there, though. So the older anti-seizure agents have a significant amount of drug interactions. Gabapentin and Lyrica, on the other hand, really are much, much cleaner drugs and have very few drug interactions, if any. And then also, the anti-seizure agents, by definition, can be sedating. So if you do use medications that have a CNS depressant effect, that can be additive. Now, the other thing that actually didn't make it on this slide is they may be sedating, much like doing the same thing we did with tricyclic antidepressants. If somebody can't sleep at night, if you give Lyrica or gabapentin and backload it and give most of the dose at night, you may help people sleep, and that in and of itself will also help the pain. So again, the question comes up of which anti-seizure agent. So if they're non-obese, if they have anxiety, gabapentin and pregabalin or Lyrica may help that anxiety. If they're obese, you can use Topamax. Now, that being said, Topamax or topiramate really is better for neuropathy or pain above the neck. I have had some luck with it for peripheral neuropathy, but it's really not the optimal agent. But that being said, if somebody's morbidly obese, remember topiramate is one half of a combination medication recently approved by the FDA for weight loss, and that's because topiramate tends to decrease appetite. Comorbid bipolar disorder or seizure disorder, oxcarbamazepine may be worthwhile, carbamazepine, valproic acid. And while I'm thinking about it, let me, moving back to the last slide actually, one of the side effects, especially with pregabalin, or especially with gabapentin, is edema, and a significant side effect with Lyrica or pregabalin can be weight gain. It's not that everybody gains a lot of weight, not that everybody gains weight, but when they do, it tends to be a significant amount of weight. The next class of drugs I want to hit on is muscle relaxers. And the interesting thing with muscle relaxers is they really don't make anybody's guidelines. But we all tend to use them. And we all tend to use cyclobenzapine or Flexeril because I think that's all the one we were taught, and that tends to have the most side effects. So basically, muscle relaxers are used to sort of help the pain by unloading the muscles. And a lot of times when you have pain, you tend to move in such a way that you protect the area in pain, which then tends to put more of a load on muscles that weren't supposed to work that hard. Those muscles get tired, they spasm. Then if you spasm enough, you can actually get, for want of a better word, small adhesions to where the muscle sort of gets stuck and locked up in a knot. That can pull on a nerve, and that can increase the neuropathy. So when you use a muscle relaxer, what you're trying to do is decrease the hyperreflexia. So, centrally acting muscle relaxers. The goal is to produce a decreased muscle tone without the loss of voluntary muscle tone. And either work directly or they work on the spinal cord. And the centrally active ones do cause sedation. If you look at the muscle relaxants to use, now again, cyclobenzaprine I think has the highest incidence of side effects. And if you look at the structure of cyclobenzaprine, it's almost like a tricyclic antidepressant. So you would have side effects that would be similar to that. People have a morning hangover, they have a dry mouth, they have urinary tension. And again, I think people use Flexeril because that's what we know. The other interesting thing about Flexeril that's come up recently is a lot of times patients will use that as a potentiator with an opiate prescription, much like Phenergan is used. I tend to like tizanidine and baclofen. And I like tizanidine because it acts similar to clonidine. It's a central alpha agonist. It tends to have less sedation than I think Flexeril does. And the other thing is, it tends to have a slight anti-anxiety effect. Now, The other thing about it, though, is as you get to the higher doses, you can drop somebody's blood pressure. But being that it acts similar to clonidine, and being the clonidine has data showing it has pain-relieving effects in the perioperative period and also CRPS, and admittedly making a huge leap of faith, I think tizanidine has become my first choice. The second one is baclofen. Baclofen works on the GABA2 receptor. It also has a small amount of anti-anxiety effects. It also causes less sedation. After that, I think it's kind of a crapshoot. Now, I don't use a lot of diazepam or any diazepam for muscle spasms, mostly because I've never found it works that well. The other reason is the data now shows that the combination of benzodiazepines and opiates have a much higher risk of accidental overdose. Metoxalone or scalaxin, I've used to various degrees of effectiveness. Dantrolene is usually reserved for neuroleptic malignant syndrome. And the one that really don't ever use, but the one patients like, is called Soma, or carisoprodol. And the interesting thing is, Soma really is not a muscle relaxer, even though it's FDA approved that way. Soma is a prodrug, and for those of you who are my age, Soma gets metabolized to meprobamate, which used to be known by the name Equinil or Miltown, and it's an anti-anxiety agent. So Soma is really not a muscle relaxer. It has a higher degree of abuse. It has a withdrawal syndrome associated with it. And the DEA has actually termed the use of muscle relaxers, a benzodiazepine, and an opiate as quote-unquote the Holy Trinity, and has targeted that combination for further review if providers continue to prescribe that at a high rate. That is being said, focused on carisoprodol, not so much the other drugs. But again, I think there's so many better muscle relaxers besides Soma that Soma is just good to avoid. And I don't prescribe it really at all. I think I have one out of my panel of patients on Soma, and they're probably going to be changed off of that soon. And the last word on Soma is, again, the combined use of Soma, alprazolam, hydrocodone produces a rush similar to heroin. Topical anesthetics, I've had varying degrees of success rate. I usually start out with lidocaine ointment because lidocaine patch is trade name only and you need to get a prior authorization usually. The other thing I like about the ointment is I think you have more control over it. You don't have to, like patches cut a certain area to fit a certain part of the body, but you could just spread it on where you need it, and it's usually 3 times a day. There are a couple of NSAID topical preparations with diclofenac using an ointment or a patch. The patch is the Flector patch. Again, I've rarely used it, mostly because of insurance company restrictions. But the interesting thing is the compounded use of the use of compounded topical products, to where there's a couple of pharmacies in this area, 2 or 3 pharmacies in this area that specialize in this, and you can have lidocaine, you can have an NSAID, you can use ketamine, you can use clonidine, you can use gabapentin, and so there's a wide range of things that you can use that work locally. And so I think this is really an option I often forget because it's not on my radar screen as much as other options, but an option that I've had as good a luck with as anything. Another topical agent is capsaicin, and some of the providers in our clinic very much like capsaicin. I tend not to use it because really for the over-the-counter preparation you have to use it for a couple of weeks. It depletes substance P from the nerve endings, and that's what helps transmit the pain, so it helps take care of the pain that way. And I'm sure you all know the trivia fact that capsaicin is what's in green chili. So you have to be careful that people wash their hands. After they use it, they keep their fingers away from their eyes, their nose, their mouth, genital areas, sensitive areas, because it can be incredibly painful if you have the capsaicin still on your fingers. And again, I tend not to use it because, you know, in my personal opinion, and this is a minority opinion in our clinic, so take mine for what it's worth, I think the capsaicin makes people more uncomfortable before it makes them comfortable, whereas the lidocaine really works pretty quickly. There is a patch called Quitenza that is an 8% capsaicin patch. You put it on the area and then remove it after a few minutes, and it depletes substance P for up to 3 months. A lot of times to use it, patients need conscious sedation, so there's that risk added onto it. Plus the fact that it's a trade name, so a lot of insurance companies will approve it. So really, by and large, I've never used this preparation for those reasons, but it is out there as a topical preparation. Some other novel agents include tramadol. And so there's some controversy, is tramadol an opiate or not? And in New Mexico it is Schedule 5, so it's treated as a controlled substance. Tramadol hits the mu receptor, which makes it like an opiate, but hits it at such a weak degree that it's hard to classify it as an opiate. The other mechanism it does is it's a weak SSRI, so it acts like a weak SSRI antidepressant. And one of the things I'm sure you all get calls from the pharmacy is tramadol cross-reacting or a drug-drug interaction with SSRIs, SNRIs. And yes, this interaction happens. However, I'm not sure that it happens to the degree that you get calls on. That being said, I've had 2 patients in a number of years who did get more irritated, did get their blood pressure went up, did get more agitated with the combination of tramadol and an SNRI. And actually, both these people were on full dose either of venlafaxine or Cymbalta and full dose tramadol. So at higher doses, this interaction can take place. So you do need to be aware of it. But I don't think that it precludes using tramadol as an SSRI, SNRI. The other thing is that tramadol inhibits 2D6, and you may have, both tramadol and some SNRIs like Cymbalta are metabolized by 2D6, so if those are used in combination, you may have increased levels of the drug, again, leading to a serotonin syndrome. So with Cymbalta and tramadol, I think the risk is higher. Venlafaxine is also metabolized by 2D6, so it is something to think about, that interaction. But again, I don't think it precludes or contraindicates the medications being used together. Nucynta is tapentadol, which is the second generation of tramadol. It's a mu agonist, much like tramadol. The interesting thing with this medication is it's a Schedule 2 drug, much like oxycodone. However, the potency of tapentadol, at least by patients who take it, say it's no more potent than tramadol. The other thing with tapentadol is it blocks norepinephrine to a greater degree than it blocks serotonin. It has a lot of the same interactions with with SSRIs, SNRIs, and theoretically, there is a withdrawal syndrome with it too, because again, it is a mu agonist, and it hits the mu receptor like oxycodone. It is not as potent as oxycodone, and it's closer to tramadol. The other thing with this agent is it's a brand name agent, and so needing prior authorization by most insurance companies, I haven't really used this medication much. Vitamin D, I think, is an easy way to help people's pain, especially with rheumatologic disorders. I mean, there's 360 days of sunshine a year in New Mexico. However, most of us aren't out in the sun. And when we do, we use sunscreen so the vitamin D isn't activated. You want a level of at least 30, and people now say greater to 6, closer to 60 to 30, and that's, quote, the therapeutic range for vitamin D. What I usually advocate is patients just taking 5,000 units over the counter daily. I think it's harder for patients to remember to take the 50,000 unit capsule once a week or twice a week versus just every day. However, for some people, depending on their health plan, if there's no copay for prescriptions, it may be cheaper for them to do it rather than buy the over-the-counter product. But one of the easy things I always check is vitamin D levels. 5,000 units a day, I think it's an easy way to help people's pain. Clonidine may help their pain, especially if their pain is a central processing issue such as CRPS. Also, possibly in some neuropathies. Remember, it's a central alpha agonist, so it blocks the flow of norepinephrine from the brain and helps block the response to pain. Usually 0.1 milligram a day or twice a day. You can go up to 2.4 milligrams, but you really want to watch blood pressure too, especially if they're on tizanidine, which works similar. One of the side effects of clonidine, dry mouth, constipation, urinary retention. However, it also might have a sedative effect that can help people sleep. Ketamine. Now, ketamine's interesting. Ketamine's an anesthetic agent, and if you use it at full dose, you do have patients fall into what's called a ketamine hole. And so whenever ketamine is used, there's usually a benzodiazepine right next to it. It is an NMDA receptor antagonist or blocker, and that may be the mechanism by which it helps pain. It may, quote-unquote, reset the opiate receptors. It does appear that it increases the concentration of endogenous opiates in the glial cells and may increase opiate receptors in the glial cells. You can have some side effects with it, obviously, anxiety, disassociation, and you can also have cardiac effects with it. There is, however, a low-dose protocol that some institutions are using that came out of Brown University with Dr. Chopra, and it's usually 50 to 100 milligrams for 5 consecutive weeks. And so 50 milligrams over 4 hours, 75 milligrams, and then 100 and 150 milligrams. And so they come in once a week for a month. The dose of ketamine is escalated up to 150 milligrams, and then they may need, like, for want of a better expression, a booster shot every month. It does appear at this low dose that there's less side effects associated with it, and that it, quote-unquote, resets the the opiate receptor levels, the opiate receptors, thereby helping the pain. And also, again, it is an NMDA antagonist. There are less side effects with the lower dose. And then the last one, and one of my favorites, is low-dose naltrexone. So this came out of a study in Stanford 2 years ago with 10 women with fibromyalgia. And when the women took low-dose naltrexone, they had an up to 30% reduction in their pain. Now, the fact that this was only done in 10 women and we're jumping on it probably indicates how much we want an answer for chronic pain. Because in any other situation, that wouldn't happen. What it looks like low-dose naltrexone may do is partially block the mu-opiate receptor, thereby sending a signal to the brain that the concentration of endogenous opiates is too low and you need to increase the concentration of endogenous opiates or endorphins and enkephalins, and then those concentrations rise. So again, it looks like it may increase endorphin concentration at the glial cells. It may also increase receptors in the glial cells. The dose is usually 4.5 milligrams, 1 to 2 hours before bed. I have increased it to twice that. But the interesting thing is this drug is relatively free of side effects. Now, they can't be on opiates when they use this, so obviously weaning somebody off their opiates to do this may be a hard sell. But the interesting thing is that the patients I've had that I've done this with, and somewhere between 8 and 10, about 70% have responded positively. Not so much that their pain's better, but that they feel better, sort of indicating that there's an increased concentration of endogenous opiates. But I like the concept of this. Again, safe. The hardest part is not being on opiates, and there is a website, www.ldn.org, and again, that's www.ldn.org. And it looks like this is being used for everything from cancer pain to every autoimmune disease to irritable bowel disease. And again, I think if you can convince somebody to go off their opiates and try it, it's definitely worth a shot. So closing thoughts. Treating chronic non-malignant pain, like I said in the first lecture, it's complex. There's many interactive thoughts going on below that, such as depression, financial issues, self-esteem issues, work issues. But treating chronic disease is like treating any other chronic, or treating chronic non-cancer pain, I'm sorry. Treating non-cancer pain is like treating any other chronic disease. There's a behavioral part, there's an exercise part, there's a sleep part, there's a diet part. As with other chronic diseases, again, never just medication, as I just stated. The same principles of adjusting medicine apply as with other chronic conditions, and that we talked about in the first lecture. So again, I think being able to remain neutral with all these medications, because these are hard patients to deal with sometimes, and they sometimes tax your patients. But the ability to remain neutral, not let your emotions get involved, treat it like every other chronic disease, and monitor the medications you use like every other medication used in every other chronic disease, tends to decrease the ability to make bad decisions. And always keep an open mind, but also let your eyes believe the data. And one of the things I finally figured out is that the patients with chronic pain that I usually miss something with are patients I personally connect with. So I don't know if that's because I connect well with sociopaths or that I let my guard down. But what I do need to know now, though, is for patients that I connect personally with, maybe I keep my guard up higher. So it is a question of remaining neutral, but having my eyes believe the data. And thank you again. Thank you for allowing me to do this via tape. If there are questions, please feel free to email me at edole, D-O-L-E, at salud.unm.edu. So again, edole at salud.unm.edu. Give me a couple days to respond. And if I don't, feel free to email me again. And again, thank you to New Mexico Health Resources for, one, asking me, and two, allowing me to tape the lecture. So on my birthday, which is June 21st, during your conference, I will be thinking of you. And hopefully you all like